Sixth lecture in the series on ECG basics. ECG in coronary artery disease. ECG changes in coronary artery disease can be in any of the waves or segments. Diagnosis of acute myocardial infarction in the emergency room still relies mostly on the ECG, though other investigations are there to supplement. P-wave, being an atrial event, is not usually involved directly by CAD, but indirectly there can be evidence of atrial enlargement if there is left ventricular dysfunction. Atrial arrhythmias are observed in atrial infarction. PR segment contains the atrial repolarization wave or TA wave, though it is not usually evident. PR segment depression can occur in atrial infarction and pericarditis. Pathological Q waves are noted in old myocardial infarction. Following features are important in recognizing a pathological Q wave. 1. Width of 1 mm or more. 2. Depth of 25% or more of the ensuing R wave. It may be noted that width is more important than depth in recognizing a pathological Q wave. All Q waves are not due to old infarction. Q waves may be seen in hypertrophic cardiomyopathy and muscular dystrophy. Loss of R-wave progression in anterior leads is a commonly sought feature of old anterior myocardial infarction, but it may be noted that this can also occur in emphysema. Normally, the amplitude of R-wave increases from V1 to V5 or V6, while S-wave decreases in amplitude. ST segment abnormalities are common in the acute stage of myocardial ischemia and infarction. It is usually mentioned that subendocardial ischemia produces ST depression, while transmural ischemia produces ST elevation. ST elevation is an important feature of ST elevation myocardial infarction or STEMI. ST elevation, which is upsloping in the hyperacute phase of myocardial infarction, becomes convex, curved in the evolving phase when the T waves get inverted. ST elevation in hyperacute phase of myocardial infarction is known as Paddy's sign. ST depression in acute ischemia may be upsloping, horizontal or downsloping. Of these, upsloping ST depression is least specific and can occur as a normal variant. Downsloping ST depression is also seen in ventricular hypertrophy with strain pattern, including hypertrophic cardiomyopathy. ECG in hyperacute phase of inferior wall myocardial infarction with 2 to 1 AV block. There are 2 P waves for each QRS complex, indicating a 2 to 1 AV conduction. Upsloping ST segment elevation, Paddy's sign, is seen in leads 2, 3 and AVF, inferior leads. T waves in these leads are tall compared to the amplitude of the QRS complexes. ST segment depression is seen in 1 AVL V1 to V6. ST depression in 1 AVL V1 V2 are downsloping, while those in V3 to V6 are horizontal. T inversion is noted in V1 and V2. T wave abnormalities are common in myocardial ischemia and infarction but lack specificity. T inversion in anterior leads can occur as a normal variant in younger individuals. Juvenile pattern or juvenile T inversion. Ischemic T inversion is usually symmetric and arrowhead-like, while that due to hypertrophy strain pattern is asymmetric. Tall T waves with upsloping ST segment may be seen in hyperacute phase of myocardial infarction, though it can sometimes be a normal variant. When in doubt, repeating ECG after a short period of observation to look for serial evolution or supplementary investigations like echocardiography are useful. This is mandatory when the clinical history is in favor of myocardial ischemic pain. ECG in myocardial infarction shows classical evolutionary changes as time passes from the onset of acute myocardial infarction. In the initial stage, there is slope elevation of ST segment and tall T waves. The upsloping ST segment smoothly merges with the ascending limb of the T wave. This pattern is known as hyperacute phase of myocardial infarction. ECG of inferior wall infarction shown above is an example of hyperacute phase. The next phase is evolved phase, in which T wave starts getting inverted while the ST stays elevated, producing the convex upwards ST elevation. Along with this, there is formation of Q waves or QS complexes in the leads oriented to the infarcted segment. Pathological Q in myocardial infarction has a duration of at least 40 milliseconds and is at least one-fourth the amplitude of the ensuing R wave. In inferior wall infarction, Q waves are seen in leads 2, 3 and AVF. In anterior wall infarction, Q waves are seen in leads V1 to V6, though the extent may be variable depending on the extent of infarction. In true posterior wall infarction, instead of Q waves, tall R waves are seen in the anterior leads V1, V2, being the mirror image of Q waves which would have been picked up in posterior chest leads. In right ventricular infarction, ST elevation is noted in the right chest leads V3R and V4R, often associated with lesser degrees of ST elevation in V1. After the acute phase, ST segment returns to baseline while Q waves and T inversion persist. In the long run, T waves may also become upright so that pathological Q waves may be the only manifestation of an old myocardial infarction. In some cases, especially if the infarcted territory was small, as in case of inferior wall myocardial infarction, even the pathological Q waves may disappear in the very long run. Thus, the ECG may be passed off as normal if taken decades after a small myocardial infarction. Unlike in acute myocardial infarction, ST elevation in pericarditis does not conform to any vascular territory. In pericarditis, ST depression is noted in leads oriented to the ventricular cavity, AVR and V1. All other leads show ST elevation. ST elevation and T wave inversion does not coexist in pericarditis, unlike in myocardial infarction. In pericarditis, by the time T wave becomes inverted, ST elevation would have subsided. ECG showing acute anterior wall myocardial infarction with right bundle branch block. Gross ST segment elevation is seen in anterior leads with maximum 0.7 mV elevation in V4. QR pattern in V1 suggests anterior wall myocardial infarction with right bundle branch block. Negative P waves in V1 indicate left atrial overload as a result of extensive myocardial infarction and left ventricular dysfunction. ST segment depression seen in inferior leads could be either reciprocal change or ischemia at a distance, which can be clarified only after coronary angiography to document whether the right coronary artery is involved or not. There is a supraventricular ectopic beat seen in the augmented limb leads AVR, AVL and AVF and the corresponding segment of the rhythm strip. This beat is premature, has a P wave with a different morphology, narrow QRS and is followed by a pause. ECG in old anterior wall infarction with RBBB and LAHB. Slurred S waves in lead 1, AVL and V5, V6 are suggestive of right bundle branch block. The terminal slurred R wave in V1 is also in favor of RBBB. Instead of the RSR pattern, there is a QR pattern in V1. This pattern is also called QRBBB. The initial R of the RSR prime pattern expected in RBBB was knocked off by the myocardial infarction. There are Q waves in V1 to V4 suggestive of old anterior wall myocardial infarction. Inverted T waves in V1 to V3 can be accounted for by RBBB as well as old myocardial infarction, but the ST segment is elevated, indicating the contribution of myocardial infarction, possibly with a dyskinetic segment. There is left axis deviation of QRS with RS pattern in leads 2, 3 and AVF, suggestive of left anterior hemiblock. The PR interval is normal. The combination of left anterior hemiblock with right bundle branch block is called bifascicular block. ECG showing acute infralateral myocardial infarction. ST segment elevation is seen in infralateral leads 2, 3, AVF, V5, V6, indicating infralateral ST elevation myocardial infarction. There is a discordance between the ST segment in AVL and V6. There is ST segment depression in AVL, while the ST segment is minimally elevated in V6. Differential diagnosis of this pattern is an early repolarization pattern, but ST segment depression in AVL is unlikely to be seen with early repolarization. Clinical history, estimation of cardiac troponins, and echocardiography to look for wall motion abnormality will help in differentiating the two conditions. ECG showing ST segment elevation in leads 2, 3 and AVF of about 3 mm. ST segment depression is seen in leads 1 AVL and V1 to V5. Overall features are suggestive of hyperacute phase of inferior wall myocardial infarction with reciprocal ST segment depression in anterior leads. The reciprocal ST depression in anterior leads could be just an electrical phenomenon due to the ST segment elevation in inferior leads or due to ischemia in the corresponding territory. We will see what exactly was there in this case in the still pictures of left and right coronary angiograms below. Right coronary angiogram shows a critical lesion with some negative shadows distal to the lesion suggesting thrombus. You may be tempted to believe that this is the culprit lesion which has caused the inferior wall infarction. Generally, the ST elevation is more in lead 3 in right coronary occlusion while it is more in lead 2 in circumflex occlusion. But in this case, we have almost equal ST elevation in leads 2 and 3. Let us view the left coronary angiogram below and decide. The still picture from left coronary angiogram shows total occlusion of distal left circumflex coronary artery with absent dye filling in a short segment, black arrow. Multiple significant lesions are seen in left anterior descending coronary artery, blue arrows. Significant lesions are also seen in the obtuse marginal branch of the left circumflex coronary artery. Thus, what appeared to be a single vessel disease from the ECG showing hyperacute phase of inferior wall infarction with reciprocal anterior ST segment depression, which could occur due to isolated right coronary occlusion, has turned out to be severe triple vessel disease requiring coronary artery bypass grafting. The culprit lesion which has caused the infarction in this case is possibly the left circumflex occlusion. Sometimes a small area of myocardial infarction can present with ST elevation in 1 and AVL, sparing V5 and V6, which are usually seen together in lateral wall myocardial infarction. Such a small infarct has been called high lateral wall infarction. This could be due to occlusion of a diagonal branch of the left anterior descending coronary artery or an obtuse marginal branch of the left circumflex coronary artery. ECG showing high lateral wall infarction. Q waves are seen in 1 and AVL but not in V5 or V6. Curved ST segment elevation minimal and shallow T inversion are seen in AVL. Detection of myocardial infarction in ventricular paced rhythm is often difficult due to the baseline abnormality in depolarization and secondary abnormality in repolarization. Usually, right ventricle is paced from the apical region. If pacing is from the right ventricular apex, the paced rhythm will have a wide QRS complex of left bundle branch block morphology. Wide upright QRS complexes will be seen in leads 1 and AVL and negative QRS complexes in 2, 3, AVF, V5, V6. Secondary to the change in sequence of ventricular depolarization, there will be secondary changes in the ventricular repolarization in the form of STT changes opposite in direction to the QRS polarity. This would mean mild ST segment depression and T wave inversion in 1 and AVL and mild ST segment elevation with upright T waves in 2, 3 AVF, V5 and V6. But if an ECG prior to myocardial infarction is available, careful lead by lead comparison will make detection of a fresh myocardial infarction rather easy. This should of course be complemented by clinical evaluation and estimation of biomarkers of myocardial necrosis. ECG showing paced rhythm with anterior wall infarction. Large amplitude pacing spikes are seen before each QRS complex, indicating unipolar ventricular pacing. Lead 1 and AVL shows left bundle branch block pattern with slurred R waves, and inferior leads show negative QRS complexes. Together, these patterns suggest pacing from the right ventricular apex. Dissociated P waves suggest complete heart block as the reason for pacemaker implantation. Missing P waves are obscured by the QRS complexes. T waves are inverted in leads V2 to V6 in the presence of negative QRS complexes. Concordant T waves. This would suggest a primary T wave abnormality and hence the associated myocardial infarction. Careful scrutiny of the ST segment shows mild coving of the ST segment in anterior leads, best noted in V3. Right ventricular apical pacing prior to infarction in this case is demonstrated in the previous ECG of the patient shown here. Review of this ECG, though partially faded, showed upright T waves in anterior leads. This, in addition to the clinical history of anginal pain, wall motion abnormality on echo, and elevated troponins, confirmed the possibility of an anterior wall myocardial infarction. Pacing spikes, LBBB pattern of QRS complexes in one end AVL, and dissociated P waves indicating pre-existing complete heart block are seen in this ECG as well. Here we highlight the need for preserving ECGs for future analysis and comparing them for accurate diagnosis. Primary ST and T wave changes are due to primary myocardial disease, either ischemia or some other cause. Secondary ST and T wave abnormalities are changes secondary to change in depolarization sequence. Conventionally, it is presumed that repolarization sequence is opposite to that of depolarization, meaning that the myocardial region to be depolarized last becomes repolarized first. That is why both QRS and T wave have same polarity. This changes when the depolarization sequence is changed, as in bundle branch block or other conduction abnormalities like pre-excitation syndromes. That is why ST segment depression and T wave inversion are noted in lateral leads in left bundle branch block and left ventricular hypertrophy. Primary T wave abnormalities due to ischemia or myocardial disease usually manifest as symmetrical T inversion, where the descending and ascending limbs of the T waves are of similar slope. T wave inversion in secondary causes have asymmetric T inversion, with descending limb having a shallower slope than the ascending limb. Downsloping ST segment in these cases usually merge smoothly with the descending limb of the T wave inversion. Left bundle branch block is manifested on the ECG with wide QRS, deep slurred QS complexes in V1 and slurred R wave in V6. ST segment and T wave vectors are discordant to the QRS vector, meaning that when QRS is positive as in V6, the ST segment will be depressed and T wave will be inverted. This is secondary STT abnormality. If the ST segment and T wave are concordant to the QRS, it indicates a primary myocardial abnormality. An elevated ST segment and an upright T wave in V6 with a positive QRS is taken as an evidence of myocardial infarction or ischemia in the presence of LBBB. Other evidence of myocardial infarction in the presence of LBBB are typical chord ST elevation, prominent R waves in V1 and Q waves in V6. Usually, the initial R wave in V1 and initial Q wave in V6 represents initial left to right activation of the interventricular septum. In LBBB, the initial left to right activation of the septum is absent. Sgarbossa electrocardiographic criteria is one of the most validated tools to help in the diagnosis of STEMI with LBBB. A Sgarbossa score of 3 or more has 98% specificity for acute myocardial infarction with angiographically confirmed acute coronary occlusion. Other criteria described are Sylvester 10% RS criteria and Smith 25% S-wave criteria. All these have concordant ST segment elevation in common with Sgarbossa criteria. Sgarbossa criteria for discordant ST segment elevation is 5 mm or more. Sylvester 10% RS criteria is ST segment elevation which is 10% or more of absolute S minus absolute R plus STEMI limits ST elevation required for the given lead. Smith 25% SY criteria is ST elevation 25% or more of the S wave amplitude. Another new criteria for computerized interpretation is based on ST segment elevation in relation to the QRS area in the presence of LBBB. In this era of primary angioplasty, it is important to recognize the infarct-related coronary artery from the ECG prior to cardiac catheterization. During primary angioplasty, usually first the angiogram of the non-infarct related coronary artery is taken using a diagnostic catheter. Then a guide catheter is introduced into the infarct related coronary artery and a few diagnostic shots taken, soon to be followed by primary angioplasty. This is to ensure reperfusion of the infarct related artery at the earliest. In anterior wall myocardial infarction, it is the left anterior descending coronary artery which is occluded, and maximum ST segment elevation is noted usually in lead V2 with lesser degrees of ST elevation in adjacent leads. If it is a more distal occlusion of the LAD, ST elevation can be noted in leads V2 to V6 and sometimes in inferior leads. This is because a type 3 LAD wraps around the apex of the left ventricle and supplies the inferior wall. In this case, though ECG shows a seemingly more extensive infarction involving inferior and anterior walls, it is actually a smaller area of infarction sparing the proximal interventricular septum. Inferior wall infarction is usually due to occlusion of the right coronary artery. If it is associated with ST elevation in right chest leads, V3R, V4R, it is due to right ventricular infarction and indicates a more proximal occlusion of RCA as right ventricular branches originate from proximal portion of the RCA. Inferior wall infarction could also be due to occlusion of a dominant left circumflex coronary artery. In that case, it is usually associated with posterior and lateral wall infarction. ST elevation is noted in inferior 2-3 AVF and lateral leads 1 AVL, V5, V6. Posterior wall infarction is identified by tall R waves in V1, V2 along with mild ST depression and upright T waves, mirror images of Q, ST elevation and T inversion. In inferior wall infarction due to RCA occlusion, ST elevation is maximum in lead 3, while in LCX occlusion, it is maximum in lead 2. In left main coronary artery disease, there is usually ST segment elevation in AVR with ST segment depression in a large number of other leads. Similar pattern can also occur in severe proximal multivessel coronary artery disease. Lead AVR is often neglected during the analysis of ECG tracings, but the importance of scrutinizing AVR in the setting of acute coronary syndrome cannot be overemphasized. ECG in a person with persistent anginal pain for the past several hours showing ST segment depression in anterolateral leads along with sinus tachycardia. ST segment elevation is noted in AVR. Mild ST depression is seen in leads 2 and AVF. Such a pattern is consistent with significant left main coronary artery stenosis. Clinical evaluation and X-ray chest showed features of pulmonary edema. Angiography done after initial stabilization with intensive medical management showed severe stenosis of distal left main coronary artery along with multiple lesions in all the 3 vessels, making a standard indication for an urgent coronary artery bypass grafting. A similar ECG pattern can also occur in severe proximal triple vessel disease. The previous ECG is given below for comparison, which shows minimal changes. But the ST segment elevation, minimal in AVR is seen. This highlights the need for serial ECGs in acute coronary syndrome, as initial ECGs may be normal even in those with severe disease. In this ECG, ST segment elevation and T wave inversion are present in 2, 3 and AVF, the inferior leads. ST segment is curved and T waves are inverted in V5 and V6, the lateral leads. Minimal ST segment depression is seen in lead 1 and AVL, which can be taken as reciprocal to the ST segment elevation in inferior leads. There are tall R waves in V1 and V2 with R by S ratio more than 1 and ST segment depression with upright T waves. These features are suggestive of posterior wall infarction, being the inverse of Q wave, ST elevation and T inversion, which would have been recorded in a posterior lead. Together with the changes in inferior and lateral leads, the full diagnosis is inferior, posterior and lateral wall infarction. This combination can occur in occlusion of a dominant left circumflex coronary artery, which supplies the inferior, posterior and lateral walls of the left ventricle. A distal occlusion of a dominant right coronary artery can also cause this pattern. A more proximal occlusion of right coronary artery would produce right ventricular infarction and null out the ST segment depression in anterior leads seen in true posterior wall myocardial infarction. Very often in STEMI, ST depression is noted in the territory of the non-infarct related artery. For example, ST depression in inferior leads in anterior wall infarction and vice versa. It has always been debated whether this represents a purely electrical phenomenon, that is reciprocal change, or true ischemia in a different vascular territory, ischemia at a distance. Experience shows that both possibilities can occur. If one coronary artery has got occluded silently long back and the territory is being supplied by collaterals from another territory, heterocollaterals, if the feeding artery gets occluded later, it is quite reasonable to have changes simultaneously in both vascular territories. ECG manifestations of old myocardial infarction is quite variable. Some small myocardial infarctions leave no sequelae on the ECG after a few years. In anterior wall infarction, old infarction can manifest as poor progression of R waves. Otherwise, the hallmark of old infarction is the presence of pathological Q waves. ST segment usually is isoelectric but can remain elevated in left ventricular aneurysm and dyskinesia. A dyskinetic segment of myocardium is one which bulges out in systole instead of contracting and moving inwards. Persistence of ST segment elevation long after myocardial infarction, usually over 6 months, was considered a surrogate sign of left ventricular aneurysm in the era when easy access to imaging like echocardiography was not available. Sometimes ST segment depression may be noted due to associated left ventricular hypertrophy or even due to transient ischemia in another territory at the time of recording. T waves which are inverted in recent infarctions may become upright as time passes, but may remain inverted for a variable period of time, especially in large infarctions of the anterior wall. In an old infarction with significant left ventricular dysfunction, left atrial overload pattern may be noted due to dilatation of left atrium. This ECG shows sinus rhythm at around 75 per minute with pathological Q waves in inferior leads indicating old inferior wall myocardial infarction. Pathological Q waves are usually 40 millisecond in width and have an amplitude of more than 25% of the ensuing R wave. T waves are inverted along with pathological Q waves in leads 3 and AVF. R wave voltage is high in V5 and V6, indicating left ventricular hypertrophy. The presence of mild ST segment depression in lateral leads may indicate fresh ischemia. If the ST segment depression was due to LVH, it would have been downsloping associated with T wave inversion, that is LVH strain pattern. Here it is almost horizontal ST segment depression, which is usual with acute ischemia. Tall T waves in V4 to V6 can occur due to any of the following: ischemia, hyperkalemia, or left ventricular volume overload. But tall T waves in V2 and V3, in which the predominant QRS is negative, is unlikely to be due to left ventricular overload, in which it is usually in leads with tall R waves. In this case, it is more likely to be a manifestation of ischemia, as indicated by the associated plain ST segment depression. In left ventricular volume overload, the ST segment usually shows a mild concave upwards ST segment elevation. Look out for the next video, which will start with ECG changes in pulmonary embolism.